1 minute बचा है वैसे।
उसको सर उतना टाइम लगता है।
6:59
लफड़ा हो गया रे, 1 मिनट मेरा फुल स्क्रीन नहीं हो रहा है
सर।
ऊपर जाके स्लाइड शो कीजिए सर, इधर स्लाइड शो है ऊपर, यस उसके बाजू में, यस गो देयर, हाँ प्ले फ्रॉम करंट स्लाइड, इधर ऑन द लेफ्ट देखिए फ्रॉम बिगिनिंग।
So in the lower row
it's not,
हाँ अभी लेफ्ट में बराबर, उधर ही लेफ्ट में एकदम लेफ्ट एक्सट्रीम फ्रॉम बिगिनिंग, क्लिक ऑन दैट।
yeah, that's the one.
no, nothing is happening.
सर कट करके दोबारा कर लीजिए।
I think you have to start again.
Okay,
रीस्टार्ट कर लीजिए।
Sometimes it hangs, then it's stuck.
Okay now?
Yes.
Full screen?
Yes, full screen.
Yes.
Leave it like that. Don't worry about it.
Rishi, are we live?
We are going live in 5, 4, 3, 2, 1. We are live.
Yeah. Good evening, everyone. We welcome you all to Ortho TV in association with Orthopaedic Research and Education Foundation. This is the longest running postgraduate teaching series online, not only in OrthoTV, but compared to any other postgraduate program. This is the longest running series, and this is thanks to the efforts of the secretary, Dr. Janki Bhadani, and the chairman, Dr. John Mukhopadhaya. It gives me great pleasure to hand over the proceedings to the chairman, Dr. John Mukhopadhaya, to introduce today's speaker.
Thank you, Neeraj, and welcome everybody to today's program from Orthopaedic Research and Education Foundation, brought to you through OrthoTV. So today we have the pleasure of having with us Dr. Vikas Agashe, a very good friend of mine and a well-known figure, especially where bone and joint is concerned, who's working as a consultant at Hinduja Hospital in Mumbai. And today is going to talk to us about surgical debridement. What are the essential steps and importance of a good debridement to combat infection? So with great pleasure, I would hand over to Dr. Vikas Agashe to give us his talk today. Over to you, Vikas.
Thank you very much, John and Janki, as well as Neeraj. I sincerely thank OREF Foundation for this invitation. So, first and foremost, I wish to thank all these friends and colleagues who have been extremely helpful as regards management of infections is concerned, because essentially it's a team effort. You can't, only orthopedic surgeon cannot manage this. So what is debridement? The Wikipedia definition is medical removal of dead, damaged or infected tissue, which improves healing potential of the remaining healthy tissue. Oxford definition is removal of damaged tissue or foreign objects from a wound. So friends, we do all this so that the population of microbes goes down so much that body's defense mechanisms and antibiotic can take care of them. Now, how do you plan debridement? What is important is what Dr. Asim Parekh, Professor Emeritus from Nair Hospital says. Surgery occurs in mind space. What happens in theater is carpentry. So a good planning is required, whether it is a total knee replacement or debridement is concerned. Unfortunately, most of the places in our country, most of the hospitals, debridement is relegated to the junior most person and is told, chalo, 2 taka laga do. Well, it is an extremely important thing. So it plays a very major role, whether it is open fracture, early surgical site infection, delayed infection, late infection, infection in spite of implant removal, hematogenous osteomyelitis, post-arthroscopy osteomyelitis, whether it is soft tissue infections of various kinds, debridement plays a very major role. Also, some questions need to be answered as to when do you do debridement, how extensive should be debridement. And two integral parts of this is the samples, when, how, and why should you take samples. And lastly, whether you retain or remove implants. So let's consider some clinical scenarios as far as open fractures are concerned, and we'll start with open fractures. Remember 5 main dictums in management of open fractures. Step 1, first dictum is, there are several publications. You will come across these publications: intramedullary annealing versus external fixator, external fixator as primary and definitive treatment. Remember, all these tell us the truth, but not the complete truth. In fact, there is too much stress on the hardware. Remember, debridement should proceed before skeletal stabilization. And because of all these articles, you come across cases like this, where the wounds are terrible and fixators or internal fixation has been done. Now, this second dictum is something which is contrary or contradictory to our talk. This book, which was published in 2020, Standards of Management of Open Fractures by British Orthopaedic Association and British Association of Plastic and Reconstructive Surgeons, BAPRAS, published 2 years ago, says that delete the word debridement. There should be no word like wound debridement. What is this? What nonsense is this? No, it is important because they say that debridement really doesn't convey the actual meaning. The actual meaning is excision of the wound and extension of the wound. Whenever you are dealing with contaminated tissues or infected tissues, you excise the area and extend the area to have a good excision. So the third dictum is, don't judge the limb by X-rays. You see excellent reduction, but if this is the kind of limb, it is useless. You need to have a limb like this. Fourth is, you must get good clues for naked bone and tissue, ideally within 3 to 7 days. And therefore, you must partner with plastic people. The idea is, you must debride so well that plastic surgeons are able to cover it well. Now, Dr. Deen Dayalan always keeps saying that courage during debridement stems from efficiency of your plastic surgery colleagues. And therefore, you must partner with plastic people. And last but not the least is, debridement and skeletal stabilization are 2 different procedures. Re-prepare and re-drape and then only stabilize. With this, we'll discuss some contentious issues about debridement. Should you debride at all? Grade 1 open fractures in pediatric age group. There have been several papers. Most recent one is just a year ago, that you need not debride open fractures in pediatric age group. Grade 1 open fractures in pediatric age group. Should you use tourniquet or not? Open fractures with small wounds with internal compounding. That means the bone has come out and gone back. Should you just excise the skin and subcutaneous tissue and then suture it off? Or should you get the bone ends out of the wound? And lastly, whenever there is massive stripping of periosteum and gross contamination of fragments, how do we address? How do we address a fragment which has no periosteum and is grossly contaminated? There is always a confusion about how to tackle that, because otherwise the bone loss would be significant. So let's start with open fractures, grade 1 open fractures in pediatric age group. So whatever the so-called evidence says, avoid not debriding open fracture, whether it is grade 1 or grade 0. Every open fracture should be described, should be debrided. This poor fellow presented on 5th day of injury, admitted, observed, and going by that protocol of not debribing, giving only antibiotics, the poor fellow developed gas gangrene and had to be amputated. Tourniquet, generally useful. It avoids unnecessary bleeding and helps dissection. However, it should not be used for a long time. Use it intermittently. There is always a post-tourniquet hyperemia, which is useful to identify between viable and non-viable tissues. I generally use it for 30 to 45 minutes and then release the tourniquet, reapply again. Now, open fractures with small wounds. Just to give an example, this young boy fell down in garden and the relatives came and showed me this X-ray. Here you can see the end of ulna is jutting out of the bone, which is obvious even on X-rays. And you can see there are some foreign bodies there. But when he actually presented, the protruding ulna was already pushed in and slab was applied. He had a fall in garden, and as I said, it is obvious on X-rays also, there is a contamination. There are small pieces of possibly sand in the wound. So how do I manage? Should I give a wash-in casualty? Should I reduce these fragments? And how do I debride? Should I take excise like this? Should I excise and extend like this? Should I excise and extend like this, or this, or this? All these questions need to be answered and related to the fracture pattern. So wound and fracture pattern helps you in deciding how to debride. And lastly, how do I debride? Should I just excise the skin and subcutaneous tissue? Should I open the deep fascia? Should I explore the ulna and deliver in the wound? Should I explore the radius in addition to ulna? Lastly, all this go together. How do I stabilize? And what approach do I use for ulna? What approach do I use for radius? So all this planning needs to be done before even entering the operation theater. So my thinking about grade 1 or any open fracture, whenever there is an open fracture, you can see that there are always some microbes on the skin as well as outside. So moment the bone comes out of the wound and goes in, the skin organisms as well as other contamination enters the body. By the time patient reaches the hospital, very often, like this patient, the protruding fragment is pushed inside. With that, it takes these contaminated pieces. All that has reached the deep surface, even beyond the bone. By the time he is taken to OT, the microbes have multiplied. By the time, then you give wash, and though it takes away most of the contamination, the deep contamination remains. So if you just debride the skin and subcutaneous tissue and put either nail, plate, external fixation, anything, the deep contamination will persist. And till the time antibiotics are on, it will remain subdued. Moment the antibiotics are stopped, the infection will become obvious and is likely to come out from another area, from another sinus. So my procedure of choice is, after the wash, part is prepared and draped, wound is extended and excised, necrotic fascia and muscles are addressed, as you can see here, and then bone fragment is delivered in the wound and cleaned. Very often you would find contamination, significant mud inside the marrow cavity, which is removed. Both the sides, the deeper areas are also cleaned and contamination removed. Once you deliver the bone piece, you are able to clean the contamination from deeper areas. After that, the soaked dressings are removed and consider fixation as an independent procedure. Part is re-prepared, re-draped, new instruments are used, and then you can do whether you want to do external fixation, internal fixation, whatever. So with that planning, this is how we manage this case. Here you can see the ulna is fractured distally as compared to radius, and therefore we need to excise this, but we need to extend the wound so that the distal ulna fracture, which is distally situated, can be exposed well. So this is what I did. Exposed the ulna, delivered in the wound, debrided it. I realized that the piece which had come out, part of it was extremely contaminated, was mud there. So I just excised that piece of that angle of ulna or spike of ulna. Then expose the radius because there was significant soft tissue interposition. Working on both the sides of ulnar nerve, we exposed the radius. And then that was the end of one good surgical procedure. Again, as I said, second surgery started with fixation of radius ulna using tense nail or whatever nails you use, whether you use stainless steel or titanium does not matter. And here you can see there's a distinct defect in the ulna where that bone spike I had excised. That's post internal fixation. The wound had to be kept open because obviously there was some defect. And on third day we did a split thickness graft. This is at 4 weeks. This is at 6 weeks. And this is at 8 months. Excellent healing. Once you are doing an internal fixation, that small spike does not matter at all, especially in children. Why in children? Even in adults. That's the function. So best to excise badly contaminated bone. So this may appear impractical, but consider the number of open fractures which get infected. In some papers, the infection rate is 50 to 60%. So therefore, you need to be very, very careful and manage these cases. Now, when you have extensive contamination like this, markedly comminuted fracture, as you can see here. So this patient presented to us at about 10 hours. He had an open fracture ulna with close comminuted radius, had a compartment syndrome, and the surgeon had done a fasciotomy, debridement and fasciotomy, and then referred to us. Now the fasciotomy was done from dorsal side. He had no sensations and some movements were there. So what was the plan? Here we could see that this part of the ulna was extremely badly contaminated, distinctly contaminated. So the planning was, we must achieve excellent wound. That is the basis. So we must excise the contaminated skin, contaminated soft tissues, and we decided to excise the contaminated ulna. Re-prepare and re-drape. We decided the fracture pattern was such that any other internal fixation would have been impossible. So we decided that if we can have a good wound at the end of the procedure, then we will try and plate the ulna without additional soft tissues. Volar fasciotomy because we had to, compartment syndrome had to be addressed, and use that to approach the radius, excise the radius to match the ulna, then close the ulnar wound. Radius implant will have a soft tissue cover and split thickness graft for radius. So all this planning needs to be done before you enter the theater. And then you can see the good, very good debridement, and we were quite satisfied so that we could slide the plate. Here you can see part of the soft tissues, part of the muscles were kept intact because they were not contaminated. So we excised the ulna, The remaining ulna was decent. Soft tissues which were bad were excised. And here we have a good wound. This is a volar fasciotomy. We excised the radius to match the ulna, plated both the fractures, and his sensations recovered by 24 hours. His muscles started working, and that is him at 6 weeks, 4 months, and that's the function. So everything depends on excision of the wound, extending the wound. Now, if there is a massive stripping of periosteum with gross contamination, how do we address? Now, I will go back to 2005, how we learned. This was a young boy who presented 5 days post open fracture in a toxic condition and DIC. You can see the flaps are necrosed. So I thought I did a great job by excising, taking out all the necrotic tissues. There were multiple pockets of pus. So I thought I had done a great job. The culture was Pseudomonas, resistant to most antibiotics. We started culture. Now, those days we used to keep debriding again and again, and this is after multiple debridements. You can see part of the bone which is the tissues are trying to cover that bone. We decided to do a split thickness graft to tide over crisis and did a cross leg flap at 6 weeks. Now this is where my third dictum comes in. You have only 3 to 6 days to cover naked bone, not 6 weeks. So this is what we did. We detached the graft flap at 6 weeks, at 2 weeks. Now remember, we have covered at 6 weeks. This is 17 years ago. At 7 years, his father informed me that he has persistent discharging sinus in spite of treatment at several centers. So what could have been done differently? This case will illustrate what you should do whenever there is massive stripping and massive contamination. This patient presented at 3 weeks. You can see there is a large posterior area. There is a failed attempt at soft split thickness graft. Again, culture was very bad, sensitive only to cholesterol. There was necrotic segment. The entire gastrocnemius was lost. Posterior tibial nerve bundle was lost. Here you can see the large area of necrotic muscle. So we did radical debridement. Forget about the tissue loss. We excised and created a defect. But this defect will help us because the microbe concentration is so less that I can do whatever I want now. I have a discontinuity of muscle, big defect, no problem. I will just excise the contaminated bone. I will shorten, repair, and lengthen. So here you can see we just excised, shortened the entire extremity by about 4.5 centimeters. We could repair the gastrocnemius. Why? Because we have shortened. We could repair the posterior tibial nerve. Otherwise, posterior tibial nerve loss is an indication for amputation in most of the Western countries. Now here we could tide over the crisis in just 1 week. Here you can see we have done a split thickness graft, and in 1 week's time, by just aggressive debridement, shortening, we have achieved a clean cover. Then, of course, we lengthened. He went into non-union, but we nailed him. And this is 18 months post-op. There's decent sensation of the sole. And this is appearance at 18 months and 7 years. So with aggressive debridement, you can do whatever you want. We just converted an open infected fracture to a closed uninfected fracture with vascular bone ends. That should be the aim. That is the aim of debridement. And this is also described in a paper published in 2018, transverse debridement and acute shortening followed by distraction osteogenesis open fractures. All that is possible only if your debridement is good. Why am I saying this again and again and again? Is because of this. 52% infection rate, 63% infection rate after open fractures. And these are all relatively recent papers, 2018, 2019. So if you do a well-planned oncosurgical debridement and achieve early cover, then you are likely to have a good result in open fractures. So remember these 5 dictums. Thank you, friends. So I will open this for question answers.
Thanks, Vikas. As usual, very sort of illustrative and to the point. I think the importance of debridement is something which nobody should take lightly. I think we see a lot of situations where people have an open fracture, they put on an external fixator, and then they feel that the job is done. And if you've not debrided it adequately, you're still going to get infection, whether you put an external fixator or a cast or any kind of internal fixation. So I think if you want to succeed in the management of these open fractures, debridement is the key, and I think Vikas has illustrated this very well. So I'm sure many of you will have questions, so please ask them now, because this is your best chance to clear your doubts.
Yes, sir. One thing while we are waiting for questions is in DNB, they used to ask one more thing about ballistic injuries. So how to manage the wound in ballistic injuries, sir, in gunshot and all?
Yeah, there are 2 or 3 different things. One is if it is what should I say, not a commercial pistol or what is called ghoda. Generally, it is those small pellets are covered in a cloth. Now, generally, the temperature of those pellets is so much that the wound is not badly infected unless the patient falls down and gets contaminated. Those small pellets need not be removed. But it is that cloth which often works as a foreign body, and that causes sinus. So try to find out whether it is a desi ghoda or an imported proper pistol. If it is desi ghoda, then you need to find that cloth and take it out. But otherwise, those multiple pellets need not be removed unless they are very near the vessel or unless you can easily take them out. But multiple pellets need not be removed. Of course, aggressive debridement is needed because generally the patient falls down and gets contaminated.
Yeah, so essentially a lot of these ballistic wounds, although they may look very bad, are often not very contaminated. So I think you need to debride whatever open wound there is, and then make a decision whether it's safe to internally fix at that stage or not. And many of these gunshot wounds can be fixed primarily as long as you're sure that your debridement is adequate.
Correct.
And there's no contamination.
So those pellets don't carry contamination.
Okay. So there is one question from Jigar Gajar, is that kindly mention how to find viable muscle intraoperatively, like color, consistency, bleeding, contractility, and bone with paprika sign.
Yes.
And all, yes, sir.
With video, if possible. I don't have a video, but yes, I mean, what you say is absolutely right. You try to hold it with forceps, it generally contracts. low current, it will contract. Color will give you an indication. There have been a lot of discussion about whether we are over debribing the muscle. There was a paper where they did histopathology and said that you are over debribing muscles. But whatever it is, I mean, we are not going to do histopathology at that time. It is always better to go beyond the infected muscle and take it out. So I generally start from normal muscle and then go in.
Yeah, I think the one area where you have to be a bit careful is in compartment syndrome, because sometimes there even dead muscle will still bleed. It won't contract, it won't do other things, but you might still get bleeding from that muscle. But you have to look at the color, consistency, and all the other contractility. And if those are not there, you can assume they're dead. So anything that is dead needs to go.
One more thing is beware of deep-seated dead muscle.
Yeah,
It is quite common. Yeah. It is quite common when there is only a spike of bone which has penetrated the fascia. Then in that case, be sure that there is a dead muscle inside, in addition to compartment syndrome. So from outside, the muscle may look decent. Moment you open it, you will realize that there is a small muscle which is dead.
Yeah, always.
Yes. So another question is about what is your advice after radical debridement with bone loss? Is it to fix with bone graft or muscular technique or cement spacer or beads or internal fixation?
Yeah. If there is a bone loss, then the first and foremost is create bleeding bone ends. Now there would be different scenarios. One could be a markedly comminuted metaphyseal fracture with a small wound. There could be a small wound on the, especially that happens in femur, where there is a fragment of bone which comes out, but the wound is very small. There could be a condition where, like I showed a case where there was a markedly comminuted fracture with lot of soft tissue loss. So every case has to be dealt in different manner. The idea is, first and foremost, is get a good soft tissue cover. The aim is convert all this into a cavity which is clean, and then you can do whatever you want. You can do musculate, that is better possibly in femur. In tibia, very often people like to do a segment transport. But as I said, if the bone is outside, is contaminated, don't try to replace
it. One more question, sir, what I have. During the debridement, the first debridement of open fracture, do we need to take culture?
Yes.
Or?
Very, very important. There have been several studies, and the conclusion is pre-debridement cultures are definitely not useful. Post-debridement cultures, there are some studies which say that they are just about useful, but all in all, people have stopped taking post-debridement as well as pre-debridement cultures unless it is a frank infection. If the patient comes on third day or fourth day with frank infection, fine, take cultures. But otherwise, if patient has come in at a decent time, even up to 24 hours, you need not take cultures because it confuses you. The infection, not all who have positive culture get infected. The culture and sensitivity pattern of infected open fractures does not match with the cultures taken. That is why it confuses. John, what is your opinion?
Yeah, I think that's what most of the studies tell you, especially for the infection that open wounds get is not the infection or the bugs that they come in with, it's what they acquire in the hospital.
Correct.
So your initial culture is not going to have any direct correlation with what it eventually gets infected with. And you might, if you go on the basis of that, you would probably done the wrong antibiotic. So you should go based more on one, the amount of contamination, and second, what bugs are most commonly seen in your hospital, and then give antibiotics accordingly.
Right.
So there is one question about if we find mud inside marrow cavity, how to debride that? Should we do reaming from far ends if some contamination remains after wash?
I would use a scoop, starting with a very small scoop and take out. Start with a small scoop. Otherwise, if you take a big scoop, it will push the mud inside. Now, if there's a large area and you think that macroscopically also you think that it is contaminated, I'll take out that segment. I have very low threshold for taking out segments which are covered by mud. It's too dangerous.
So, there is another question is what you want to know some tips on debridement in chronic osteomyelitis.
I have the next talk is about chronic osteomyelitis.
Okay, sir. There are a few more questions, sir. Sir, Dr. Amay want to know there was a case which reported 2 months after bipolar got infected, but his entire right lower limb was infected from hip to ankle. Only foot was saved. Then he has written, we just made an incision at multiple level and did the serial debridement and dressings, but consultant was reluctant to take away dead tissue as his limb would have remained without any muscle. So what should be the initial approach of these cases?
Early implant removal if the infection is bad. That is number one. Number two, good reaming of the femur. Possibly in this case, the bipolar must have been kept for a long time. Even if, and it must have been removed at when the entire limb was infected. Once the entire limb is infected, the muscles get necrotic, then there is no point in saving the limb. The only way you can salvage the patient is amputation or disarticulation in this case. But otherwise, if you pick up early, then take out the bipolar depending on the sensitivity pattern. In case the pattern is very bad, in our country, very often it is carbapenem resistant bugs, then don't try to put prosthesis again. Then go wherever there is infection. Now here the entire femoral canal is likely to be infected. In that case, you need to not only scrape it, you may have to ream it. Now when you are reaming it, you need to make another window distally. Otherwise, most of the reamings may remain distally. So make a window distally and take out the reamings. Generally, if you do it within first few days, the chances that you will not have to, the patient may not get an extensive infection like this.
Yeah, I think one of the reasons why people get such bad infection is because it is missed initially. They are on antibiotics. The initial findings kind of get subdued with the antibiotics. It's like a partial sort of, not really a full eradication of the infection, just like a partial suppression of the infection and the symptoms and signs. And then things get really bad and then it explodes in your face. So the first thing is not to allow this to happen by not giving them antibiotics beyond the first 3 doses or 24 hours. Watch them very carefully. If you have any doubts, go in and debride rather than keep them on antibiotics. Okay, and if you do that, you will not allow things to get out of hand. Okay, this doesn't happen in one day. It's happened over a period of time. And in that time, most likely it's been having antibiotics, which has been suppressing the findings to some extent, but not really eradicating the infection.
Correct. So I think, can we go to the next talk?
Yes, sure.
Because that would cover what Dr. John also has said. So we will discuss about surgical site infection and we'll possibly answer the last question. What is debridement? Is it only removal of pus and implant? No. Friends, remember, pus is just a byproduct. It's dead WBCs, bacteria, tissue debris, so on and so forth, and not the source of infection. So just draining pus is not debridement. Remember, whenever you take an incision, within seconds of surgery, the surgical field is flooded with these bacteria, which keep on moving, what is called planktonic bacteria. Now, most of these bacteria are killed by body's defense mechanism and antibiotics. Some bacteria, however, succeed to attach to the implant. They also start getting attached to each other and recruit more bacteria, more planktonic bacteria. If the tissues are traumatized and avascular or the host defenses are poor, then bacteria start secreting these extracellular matrix, as you can see here, and they start getting embedded there. So within first few days, all this starts. Now, once this starts, it starts multiplying, multiple such colonies occur, and the metabolic rate and nutritional requirement of these bacteria decrease. They develop pathways for nutrients. Now, since their metabolic rate decreases and they are not coming in actual contact with body's circulatory system, the inflammatory markers may reduce. And slowly, these bacteria start getting arranged in these three layers. The superficial layer, where they keep multiplying a bit. The second layer, where the multiplication is less, their nutritional requirements are also less, and the deep, or what is called persister layer, which is just about 1% of the entire colony, and they just become non-responsive to antibiotics. In the sense, they are not resistant, but they just don't care about the antibiotics, because since they are not multiplying, their nutritional requirement is less, they don't respond. Now, this is what is called biofilm formation. It happens over the surface, under surface, through the fracture site, through screw holes. All these bacterial biofilms start going in. The antibiotics don't work. These, our phagocytes, just get frustrated. They are typically called frustrated phagocytes because they cannot work. Now, these frustrated phagocytes, bacterial toxins and biofilms start causing osteolysis. Intermittently, these films burst. Then that time they have planktonic bacteria. Once planktonic bacteria disperse, acute symptoms occur. So you would say that, he had no infection. Now all of a sudden his infection has started. That's because the biofilms have burst. All this osteolysis and bursting will often cause this implant failure. Now, if you want to salvage the osteosynthesis, then as Dr. John said, you must attack early, not with empirical antibiotics, which will kill only planktonic bacteria, but with your knife first, which will take away adherent biofilms and give you samples, will tell you what is the culture pattern, and then your antibiotics will kill planktonic bacteria. And then you will be able to salvage, implant and construct. And it is possible only within first few weeks of surgery and development of infection. So up to about 2 weeks, if you pick up the infection, then you have a pretty good chance of salvaging, implant and construct. But if you keep giving antibiotics for 10, 12, 15 days, the infection would get subdued. You will not even know, you will not pick up that this is infected. After about 2 weeks, slowly the maturation of biofilm starts. The chances of salvage become less. And of course, after about 10 weeks, there is hardly any chance of salvaging the construct. So post-plating, if you wait for too long, this is what happens. Post-nailing, this is what will happen. So your debridement has to be taking into consideration that this is the entry point in open fractures, and this may be the sinus in open fractures, and the bacterial biofilm will be from top to bottom. Considering this, we will consider if we pick up the infection early. For example, this patient presented 4 weeks post-surgery with an infection like this, just a few beads of pus. The surgeon had kept it open distally and then put staples in the ward itself. The fracture seems to be reasonably well reduced, is stable. That is the history. That is the initial surgery. And this is how she presented. 4 weeks later, she presented with methicillin-resistant Staphylococcus aureus. Now, how do we debride this? Remember, read these 2 papers, excellent papers. If we have picked up early, we will be able to address this or retain the implants. But how will you retain the implant? Excise the wound, not open the wound. Think where were the sutures. Go beyond sutures, because those marks also get infected. So excise the sutures. We have just excised the sutures. Debrided it well. Put vac to get the thing approximated. And initially did partial closure, gave appropriate antibiotics, wound bleeding well, and in about 10 days time, we could suture, the wound healed, and this is at 3 months, and this is a 14 months follow-up where we could salvage the implant. Another one, 10th day. Now here it is little more extensive. The skin loss is significant. Again, debride well. Don't worry about the loss. Your plastic colleagues can rotate a flap. So the surgeon, the plastic surgeon rotated a flap, and this is at 12 months. Now this is a little late presentation, 6 weeks with large swelling of left thigh and hip. You can see that's the incision, and this is a huge swelling here. She had sustained an atypical fracture, treated with nailing elsewhere. The aspiration was done by index surgeon. One good thing was he had not given antibiotics beyond 24 hours. And the moment he saw this swelling, he aspirated, The culture was gram-negative, Proteus vulgaris, no oral options available, but the patient was on IV meropenem for 6 weeks. So culture-specific antibiotics were given. This, at first glance, appears an extremely unstable fixation, significant virus. However, when she presented, she appeared to have a decent callus and she was actually walking. So my thinking was she possibly has a stable fixation, possibly because it has telescoped into one another. So I did keep antibiotic nail standby, but moment I opened, before opening again, the planning was, this is day 1, this is 6 weeks, the implant has not cut out. There is a decent callus at fracture site, not away from fracture site. She was walking, so possibly I have a stable construct. So how do I explore? Remember, these incisions have to be joined and excised. You need to excise these incisions together, like this. Do not excise these individually, because there would be a hematoma between these incisions also. So after a thorough debridement, we excised the incisions, vastus lateralis, and the tensor fasciae lata overlying all this en masse, scraped along helical blade and entry point, collected sample, put local stimulant beads, and decided to retain the implant. This is 3 months post-op. This is 5 months post-op. Wound dry, patient walking quite well, consolidated at 10 months. And this is at 26 months, no recurrence of anything. We were really, really lucky in this case, because this is the outer limit. Beyond 6 weeks, you will not be able to salvage. Fortunately, the surgeon had started culture-specific antibiotics. So when do we remove the implants? Remember 4 factors: stability of fixation, duration of infection, microorganism pattern, and soft tissue cover. Also, consider host physiology. If patient has multiple comorbidities, avoid retaining the implant. If clinical presentation is such that patient is going downhill and is very toxic, then avoid retaining an implant. So first and foremost, unstable fixation. Take out the implant. Delayed presentation, several weeks. Biofilm has already formed. Avoid keeping the implant. Multi-drug resistant, resistant to everything. Klebsiella pneumonia, resistant to everything. Take out the implant. And lastly, poor soft tissue cover. Inability to achieve good cover. Take out the implant. So this is as regards post-osteosynthesis infection is concerned. Do we have about 15 minutes where I can discuss osteomyelitis, or the time is over? Dr. Janki?
So,
the time is over?
We have 10 more minutes here. Sorry.
So this would take about 15 minutes at least.
Let's keep it for discussions, and then we'll take it in the next, maybe after a few weeks or something like that. Maybe.
Okay, fine. If there are any questions, I'll take them.
Yes, sir. So there is one question from previous discussion.
Yes.
Is by Dr. Ratan. He want to know which case we do directly internal fixation even in open fracture.
Yes, very important question. First and foremost, your wound has to be absolutely good. Your patient has to be stable. So stable patient, stable wound. Then you can think of, and cover possible. These 3 very important things. Patient should be stable. There is no point in fixing a femur when patient is unstable. Patient has chest problems. Don't fix it. Do an external fixation. If the wound is absolutely good, if you think that the wound is still contaminated, patient will need repeated debridement. Avoid it. And the fracture site as well as implant has to be covered. You should be able to achieve that. Then it is worthwhile fixing it. With VAC, maybe you can delay cover by about 2-3 days, but that's it, not beyond that. John, your idea?
Yeah, so I think what you have to understand is that, especially in bad open fractures, apart from the debridement, the antibiotics, the stability of the fracture is also important. So once you've done your debridement, etc., then you have to see. Now, when you look at femur and tibia for shaft fractures, diaphyseal fractures, probably grade 1, grade 2, and even grade 3A. Today, if you can do adequate debridement, probably primary nailing is all right. The problem comes in the metaphyseal fractures where nailing may not be a good option. And I think there, depending on the situation, especially if it is some region around the elbow or the distal femur, today we are going more and more towards internal fixation to provide stability rather than relying on the external fixator, which in a distal femur or an elbow does not give you very good stability. Okay, so I think you have to weigh all these things together. You look at the wound, you look at contamination, you look at the general condition of the patient. Again, you don't want to be doing heroic surgery if the patient is in a sort of precarious situation. There you would go debride to an external fixator. But where everything else is okay, I think probably today many of these metaphyseal fractures, we would go ahead and do a primary plating with debridement. Obviously, you need to get good soft tissue cover. If that's not possible, then you again delay your definitive fixation.
One more piece of advice is, if you are relatively junior,
then
do not have adequate experience, avoid doing internal fixation.
Yeah, I think
it is always, because once you do an internal fixation, you are stuck. In fact, this British Orthopaedic Association started way back that all the debridements have to be done by orthopedic consultants. The internal fixation may be done by a registrar. Now, last few years, they modified it still further, improvised it still further, and now every debridement for open fracture has to be done by orthopedic consultant and plastic surgery consultant. It is orthoplastic procedure and not orthopedic procedure. And that is why so many papers have come in stating that the timing does not matter. It has to be done by appropriate person. So if you are a registrar, not adequate experience, don't go by the literature that treatment of grade 3A open fracture is tibia nailing. Avoid it. Wait for your boss, do an external fixation, do debridement, external fixation, and the further process to be left to the boss. That may not be possible always, I agree, but at least improve your debridement skills and then do the fixation.
The other thing is, in a lot of these open fractures, today it's reasonably well recognized that unless they're grossly contaminated, there is impending compartment syndrome, obviously any vascular injuries, you don't need to do them at 2 o'clock in the morning, okay? So wait till you have adequate staff, adequate experienced people around, both for the anesthesia as well as for the surgery, and do it then. That wait of 6 hours or 8 hours or 12 hours doesn't seem to make a difference in terms of infection. Of course, if there's gross contamination, if there's any impending compartment syndrome, any vascular injury, those cannot wait. So I think you have to also not just go by a simple rule, but also use your own judgment at that time to decide what you have to do.
So one more concern about the immunity, sir, like in diabetic patient and all, do we are using something like some immunity booster or what else we can do? Because that is also a risk factor for infection.
What do you mean by immunity boosters?
Sir, if do we are giving, because few
What,
of the
what do you mean by immunity boosters? Now,
actually, sir, I have seen in few of the prescription it is written some medicine which increases immunity. Like I forgot the name, some brand name.
Medicine? So there are, so of course, so you have to deal with things like anemia, hypoproteinemia, okay, because those will affect your immunity. So those are the things, their general nutrition, etc., need to be dealt with, okay, and that is the best immunity booster that you can give them. Okay? Of course, these drugs like all these Immumod and things like that, it's untested. I mean, it's more like you're doing it for your own satisfaction than actually doing it. So there are immunoglobulins where if they're low, but you have to make sure that you're giving it for the right indication, not just blindly for every patient.
I have also never used immune boosters.
Yeah.
Honestly, I don't even know name of a single medicine which improves immunity.
Yeah, there's some of these, and it's like more. They are basically a combination of vitamins anyway, so you can give them the vitamins B complex, etc. Of course, vitamin C, etc. need to be given. If their vitamin D is low, they need to be supplemented. Because all those affect your general immunity. But giving immune medicines which improve your immunity is a myth more than a correct.
I think we have taken most of the questions, sir.
Yeah.
And,
great. Thank you very much, Vikas.
Okay. Thank you.
We'll have to repeat the osteomyelitis talk at some other day when you're feeling better. I don't want to stress you too much also.
No.
Yeah. Okay, great. Thank you very much.
Chalo, bye-bye. Bye, everybody.
Thank you so much, sir.
Bye.
It was great,
Bye.
sir.
Bye.
Thank you, sir.
Bye.
Thank you, sir.